Hello everyone, I'm here to describe regarding the prosthetic valves and its evaluation in the perioperative period and its concerns. So basically the prosthetic valves are broadly categorized into mechanical and bioprosthetic valves. In mechanical we have bileaflet valves which are St. George and Onyx, and we have monoleaflet valves which are from Medtronic, and TTK Chitra valve is also a monoleaflet valve, and caged valve which are Star Edwards. And in bioprosthetic we have stented porcine, stented pericardial patches, and stented porcine from Medtronic Freestyle, and percutaneous balloon expandable, that is Edwards Sapien, and self-expandable percutaneous, which are Cole valves. So basically the mechanical valves are either by tilting disc bileaflets, and bioprosthetic valves usually are heterographs, as we described, porcine or bovine. The durability of mechanical valves is around 20 to 30 years. Of that, of bioprosthetic valves is 10 to 15 years, and has a subsequent lower risk for replacement or repair in mechanical, whereas bioprosthetic valves are associated with higher risk. And obviously thromboembolism in mechanical valves risk is higher, whereas it is lower in bioprosthetic valves. And anticoagulation requirement is lifelong for mechanical, whereas it is minimum 3 months for bioprosthetic valves. So where it is preferred? So mechanical, basically the patient's preference is first, and mechanical valves are preferred when patient is already on anticoagulants, and when there is a risk of accelerated deterioration, like in young age patients with renal insufficiency, hyperparathyroidism, or all these patients, mechanical valves are preferred. Whereas in bioprosthetic valves, where the anticoagulation is contraindicated because of risk lifestyle and compliance, and women of childbearing age, these are the common people where bioprosthetic valves are preferred. So basically these are the introp 2D as well as 3D views of mechanical valve in mitral position, where you can see in figure B there is a normal, during the valve opening there is a normal antegrade color flow Doppler in the flow acceleration at the level of the 3 orifices. When the valve is about to close, as you can see in figure F, these are the washing jets which are seen in this types of prosthesis. Whereas in bioprosthetic valve, usually it looks like a normal appearing valve, but the basic things we can observe is the struts or the frame on which the leaflets are attached can be distinctly seen in the various echo views. So basically, as we evolved from ball and cage valve to bileaflet valve, there is achievement of larger central orifice, there is less exposed metal, there is reduced opening gradients, and there is a better durability. So as we see the ball and cage valves, which are high profile valves, we can see there's a lot of turbulent flow around the ball, and as it is evolved through the single tilting disc and the latest bileaflet, we can see a better low profile and a laminar flow. So these are the various washing jets of the mechanical valves. The first is the bileaflet valve, where we have 3 washing jets, one at the central and the 2 at the 2 lateral orifices when the valve is about to close. And in bileaflet we have 2 jets, one broader and a narrower jet. And whereas in ball and cage we have a single gush, which we can see in the given figure. So basically the bioprosthetic valves are either, as we described, are either porcine or bovine pericardial valves. They undergo various process throughout, and basically the basic difference lies here, that is the force distribution in the orifice area. If you see the porcine valves, the force distribution, the base of the leaflets is deep into the valvular structure, so it reduces the tensile strength and allows radial distribution, better radial force distribution, but it comes with a disadvantage. The porcine requires an outer fixed structure which makes the structure stiffer, and effective orifice area which is much smaller for a given size. Whereas in bovine pericardial patch, the pericardial tissue is very horizontal at the base of the structure, and this does not allow for significant force distribution, resulting in greater tensile strength. It has a superior hemodynamic profile than the porcine valves. The pericardial structure minimizes the turbulence to the blood flow and maximizes the orifice diameter. So these are the various jets seen during the intra-op TE assessment of various bioprosthetic valves. So basically the most commonly used bileaflet valves, we have one central orifice and two lateral orifice, and during opening of the valve it forms an angle, so which is known as the opening angle, and when it is about to close, it has a regurgitant volume which is a combination of the closing volume and leakage volume. The closing volume is the volume of the blood that is pushed due to the movement of the valve leaflets. The leakage volume is the volume used to prevent stasis and thrombosis on the leaflet surfaces when the leaflets are closed. So there is one more important thing which you have to know: what is the difference between the geometric orifice area and the effective orifice area. The geometric orifice area is the anatomic area of the processes at the inflow. It is calculated from the inner diameter of the processes, whereas the effective orifice area is based on the physiological parameters derived from the hydraulic principles. So, and apart from that, there is one more mechanism of called pressure recovery, where we can see in the difference in the difference between the bioprosthetic and bileaflet valves, where we have in bileaflet valves we have a central orifice. So whenever there is a narrowing, we can see that there is a decrease in pressure and increase in velocity, but as it moves forward, the velocity gradually decreases and the pressure increases. So this pressure increase is known as the recovery phenomenon. So it is this fluctuations are more seen with the central orifice, and this pressure recovery is more with the central orifice than the lateral orifice. So what is the how do you evaluate the prosthetic valve in the intraoperative period? So what type of valve is it? Is the valve well seated? Are the leaflets moving appropriately? The valve showing ring integrity and motion, the transprosthetic gradients, and if there is any regurgitation, if there is, it is either physiological or pathological, and location of the regurgitation and the severity, and are there any masses, extraneous masses present, and corresponding chamber size and function, pulmonary artery pressure. So these are the various aspects which you evaluate after the valve is placed. So coming to the prosthetic aortic valve obstruction, it is usually assessed by the pressure gradients, and then if you want in a flow independent fashion, the things to be assessed are the acceleration time, the effective orifice area, and the Doppler velocity index. So if you see the acceleration time, the normal jet is triangular with early peaking, but whereas in an obstructed valve, you can see a jet with a rounded contour, and the acceleration time is less than where the peak gradient peak velocity is attained, where the acceleration time in a normal jet is less than 100 milliseconds, whereas in obstructed jet it is more than 100 milliseconds. And coming to the effective orifice area, if you can calculate the effective orifice area by calculating the stroke volume, which can be calculated by cross-sectional area in cross-sectional area of LVOT with VTI of LVOT divided by VTI of the VTI of the jet. So this give you the effective orifice area. There is the better index, which is known as the Doppler velocity index, which is the ratio of the velocity in the proximal to the distal. That is, if you are taking up the aortic valve, it is the ratio of velocity of LVOT by velocity of jet, the velocity of the jet after it passes through the valve. So this is useful whenever the valve sizes are not known and inaccurate LVOT area is present. So coming to the assessment of the prosthetic mitral valve, here also we can assess the peak early velocity, the mean gradient, the pressure half time, and the Doppler velocity index. If you consider the Doppler velocity index, it is different from that of the aortic valve. Here it is the ratio of VTI of prosthetic mitral valve to that of VTI of LVOT. So this is the difference between the prosthetic DVI assessment of aortic valve and the mitral valve. And then next you can assess through the effective orifice area, which is as we described earlier, and other things which you can assess is pulmonary artery pressures, LA, LV and RV in detail can also be assessed to identify the obstruction. So what are the normal values? So these are the normal values for aortic and mitral. For example, if you take an aortic prosthetic valve, it is considered normal if the peak velocities are less than 3 milliseconds, and if the gradient is less than 20 millimeters of mercury, if the DVI is more than 0.3, and the effective orifice area, if it is more than 0.85 centimeters square per meter square, and the acceleration time less than 80 or 100. So these are considered normal for aortic, whereas for mitral the velocity is less than 2, mean gradient less than 5. The DVI, as we described earlier, the DVI here is different for mitral valve processes. So its value normal is less than 2.2. The effective orifice area more than 1.2 centimeter square per meter square, and then we have a pressure half time for the mitral valve, it should be less than 130. So these are the normal values. So next, coming to the concept called prosthetic patient's prosthetic mismatch, PPM, occurs when the effective orifice area, which we have already described how to calculate it, of the processes is too small in relation to the patient's body size, resulting in abnormally high post-operative gradients. So the moderate PPM incidence ranges from around 30 to 70% seen with aortic, and in mitral valve in almost equal percentage, whereas the severe PPM ranges in from around 2 to 10%. So what are the concerns of this PPM? So it worsens the hemodynamics in the post-operative period. It is a slow and less complete regression of LV hypertrophy. It can cause pulmonary hypertension. It can worsen the functional class, exercise capacity and quality of life, and can be associated with lower survival, and it is associated and faster degeneration in case of bioprosthetic valves. So how do you prevent the PPM? The selection of most appropriate type and size of the valve processes according to the target indexed effective orifice area. So once you calculate the effective orifice area, index it, and take the valve according to that. So that prevents the PPM. So apart from that, there are some anatomical issues which has to be sorted out. That is, if the root is small, the root enlargement like Conorastan, Nick procedures, all this can be done, and supra-annular implantation can be used, and stentless bioprocesses can be used, and the age-old Ross procedure is also used to prevent the PPM. So now this is like, once you place the prosthetic valves post-operatively, you got high gradients. So what are the differentials? It can be a patient prosthetic mismatch, it can be a prosthetic valve dysfunction, it can be due to high flow states, it can be due to technical errors also. So how do you go through? See, for example, if the patient is having the high post-operative gradients, you measure the effective orifice area. So if it is abnormal, abnormal, then definitely if it is less than 0.65 or abnormal, very severely less, then it is purely indicates the patient prosthetic mismatch. If it is normal, then assess the 2D occluder motion of the valve. So basically if it is abnormal, definitely it indicates the intrinsic valve problem. But if you are unable to visualize it, then the best index would be the Doppler velocity index. If the Doppler velocity index is normal, then you can definitely say that it is because of high flow states. But if it is abnormal, then you have to see at the other assessments like jet counter or acceleration time and all. For example, if in case of aortic, if the jet counter is rounded and acceleration time is more than 100 milliseconds, definitely it indicates the intrinsic valve problem. But if it is triangular on less than 100 milliseconds, which is normal, then you might have to consider the technical errors or the high flow states. So this is a broad view. How do you assess the high postoperative gradients? And then next, we usually can go through some technical errors. We have to understand these technical errors during the assessment of the prosthetic valve. For example, if you are measuring the effective orifice area, which is LVOT area into V1 by V2 as described in the figure on the left. So basically if you are taking the V2 more closer to the central orifice, then you can get abnormally more higher velocities and less effective orifice area. So that should be sorted. And for example, when you have error in measuring during the DVI, also follows the same thing. For example, if you are measuring the DVI at point A, then you might get higher values than at point B. Next, coming to the regurgitation, if we have seen the high gradients. Now if you see the regurgitation, it can be normal or it can be a pathologic regurgitation. So normal, usually it is of shorter duration, low velocity and uniform color, and low signal strength with continuous wave Doppler. Whereas pathological regurgitations are deeply penetrating jets, have a high velocity, are non-homogeneous jets, and has PISA in the proximal chamber, and anything outside the sewing ring is a pathologic regurgitation, which has to be taken care. And then next, coming to the paravalvular leaks, the problems associated with the paravalvular leaks can lead to heart failure, hemolysis, and even an infective endocarditis. The management, basically medical management, metoprolol, pentoxifylline have shown some benefit, and the intervention like vascular plugs, occluders, and ultimately the surgical revision are the options. Now coming to, for example, there is a paravalvular leak in the intraoperative period which you are assessing to the TE, then how to exactly tell the surgeon like where he has to repair it. For example, if you are taking up in the mid-esophageal 4-chamber view, for example, if you are seeing at the A2, we can see the A2P2 leaflets. So for example, if you are seeing the leak near the A2, then you can say surgeon that it is at 12 o'clock. If it is at P2, you can say that it is at 6 o'clock, and then 6 o'clock position. Now if you are taking up the 2-chamber view, mid-esophageal 2-chamber view, where you can see P1, A2 and P3 leaflets, so you can tell the surgeon accordingly that if the leak is near the P3, you can say that the leak is at around 4 o'clock position. If the leak is near P1, you can say it is around 10 o'clock position, 10 o'clock position. And then if you are taking the mid-esophageal long aortic valve long axis view, we have the A2P2 leaflets. If you are seeing the jet again at the A2 level, you can tell that surgeon it is at like 12 o'clock, and whereas of P2 you can say it at 6 o'clock. So this is a basic diagram which can help you to guide the and identify and tell the surgeon regarding the exact location of the leak. So mechanisms of the prosthetic valve dysfunction, the valves usually over a period can undergo wear and tear. It can undergo calcification, pannus formation, endocarditis and thrombus. So the difference, this is a basic difference which is asked at many points, like what is the difference between the pannus and the thrombosis. For example, the pannus chronology takes minimum 12 months, commonly more than 5 years from the surgery days. Thrombosis can occur at any time. So relation to anticoagulation, thrombosis definitely has a strong relation to anticoagulation. The location, this thrombosis where the velocities are, the flow is low, like more seen in tricuspid and mitral than in aortic. Then morphology. A pannus can be seen as a small mass, mostly involves the suture ring, and it has a centripetal growth, and it is confined to the disc plane and it can grow beneath the disc. Whereas the thrombus has a larger mass, can be a larger mass than pannus. It has an independent motion, a thin outer ring may be visible. It can project into LA or down from the mitral position. It can be identified as a mobile element. So whenever you see the echo density of pannus, you can it is more than that of the thrombus. And at the same time, if you see the CT, cardiac CT attenuation value, it is more, that is more than 200 HU than the thrombus is usually less. So basically the valves can be seated in anatomic and anti-anatomic position. Anatomic position, when the leaflets open parallel to the natural valve, it is known as the anatomic position. And how do you assess the valve on X-ray? So for example, if you are taking an AP or a PA view, you draw a line from the right cardiophrenic angle to the left atrial appendage. The valves sitting above are usually the aortic valve and the pulmonary valve, and below it are the tricuspid and mitral. So similarly, if you are taking a lateral views, you draw a line from the apex of the heart to the carina. This valve sitting above can be an aortic or pulmonary, below it can be a mitral or tricuspid. And based on the orientation of the valve also, you can identify the valve. So the anti-thrombotic therapy recommendations in patients are usually the antiplatelets and vitamin K antagonists. For bioprosthetic valves, antiplatelet aspirin daily is 75 to 100 mg is reasonable, and we have to maintain an INR goal of 2 to 3 is at least for first 3 months if there is a low risk of bleeding. In case of mechanical valves, it is considered aspirin 75 to 100 daily, and then if in AVR we have to maintain an INR goal of around 2 to 3 and or 2.5 to 3.5 if there is a risk factor for venous thromboembolism. In mitral, definitely we have to maintain little higher INR goal at around 2.5 to 3.5, and whereas in recently, like in TAVR, the suggested is aspirin plus clopidogrel for at least 3 to 6 months may be reasonable. If clopidogrel is not used, INR goal 2 to 3 for first 3 to 6 months may be considered. So in all this, we have to basically like weigh between the bleeding and the thrombotic risk of the patient. So we have various scores for it. Accordingly, we have to decide. And then I'm just going like quickly through the tables which you can later on refer for the exact evaluation. See, for example, these are the grading of aortic prosthetic valve obstructions, the various parameters which we see for normal to significant obstruction, and these are things these are the various parameters for we assess the severity of aortic prosthetic valve regurgitation. And then for example, if you are having a higher transvalvular aortic gradient, so we have already described the chart, the simpler form where we can assess the prosthetic valve higher gradients in the post-operative period, but this is specific for aortic valve, which you can go through. And similar things for mitral valve obstruction, for regurgitation, and this is the algorithm for higher mitral valve, transvalvular mitral gradients. So apart from that, we have the normal, these are the various valve sizes available. We can see that St. George and Edwards has a good effective orifice area, and we can see the recent Onyx valves. Onyx valves has a very good effective orifice area for all the available sizes, and this is for the mitral valves. Here also we can see that the effective orifice area are highest for the latest Onyx valves. So this is a brief like regarding the prosthetic valves. Thank you so much.